Hi, my name is Beth, and we are here this afternoon to show you an educational video that we put together in regards to imaging safely and wisely. We're going to be going through four different...
You're doing so good!
We're going to be going through four different projections today, and we're going to go through technique, positioning, collimation, and shielding. All of our projections will be through West Penn protocol, since we are all students of West Penn putting this video together. I hope you enjoy. 2, 1.
Hi, I'm Brandon, and I'm going to show you how to safely and wisely image a patient during a chest x-ray. First, before you get the patient, you need to set up your tube properly. You need to set it to the wall button setting, and you also need to put it to 72 inches away from the image receptor. Like so. Both of these buttons will light up green, knowing that you're locked in position. And also, your tube should not be at 0 degrees, it should be at 90 degrees, pointing right at the image receptor. Now, right now we don't know the height of the patient, so we can just right now just pick an average spot. For most patients in West Penn, we put it in crosswise 14 by 17. I'll grab the image receptor right here. See right here. And then as you see, when you open right this way, sir. You know how you're having your x-ray done today, sir?
Yes, for my chest.
For your chest. What's going on? Can you describe what's going on with your chest?
I'm having more chest pain, shortness of breath, and I keep coughing up this green mucus.
How long have you had your cough?
I'd say about a week.
About a week?
Mm-hmm.
Okay. And can you confirm your birthday for me?
3/13/81.
Okay. Thank you, Mr. Smith.
1.
And Mr. Smith, did you say you had any necklaces on or any type of metal?
No, not at all.
Okay. Alright. Alright, well that's good. I'm going to write these down and we're going to start your images. Your first image, you're going to put your chest right up against the board. If you can do that for me.
Sure.
Just like that, nice and flat. Okay. Now what we're going to do here is we're going to look at the collimator and the light field here. A good point of reference is C7, which is a vertebral prominence that you can feel on every person. And that's about T1. And from there you want to go about 7 to 8 inches down. So we've got to raise this board. It's kind of hard to see the light there. So we want to go about right there. That's about perfect. Maybe a little bit up. We also can do about an 1.5 inches above the shoulders of light. Just make sure you're centered down MSP2, just like that. Line the bucky up, of course. And then the next step is shielding. Don't ever forget shielding, especially on any patient. You shouldn't be asked to shield a patient. If you do, shame on you. Another thing before you take the picture is make sure that the person wraps his shoulders, rolls his shoulders forward, if you can do that for me, Mr. Smith, and then also wraps their hands around the bars in the back. Okay, just like that, perfect. And another repeatable error that you want to avoid is getting your left marker on here, because without this left marker, it is not a legal image. And God forbid if something happens, it's not a legal image. Double check all of your things once more. Everything's lined up, he's positioned correctly, you have shielding, and that's... Alright, Mr. Smith, the PA we set in the computer system, and now you can relax your arms, okay, and you can step away for me if you can do that.
Sure.
Okay, so for the next projection, we're going to do a lateral projection. We're going to put it in 14/17, but lengthwise. And as you see, the collimators will adjust to it. See, it's still stuck at 14 by 17 cross, but as soon as you put it in like that, it will adjust immediately. Okay, Mr. Smith, go ahead and take a step towards me. I'm going to put up this bar for you to get your arms out of the image. Go ahead and put your arms on the top bar if you can't reach it. Great job. Okay, so now we're going to center down the mid-coronal plane. Go ahead and take a step forward for me, Mr. Smith. Keep going. Just like that. A good point of reference is the same point. You want to center about T7, but also remember that a good point is the axillary above your armpit. So we're about axillary point right now. But what we can also do is, you see the top of the light field is up top here. And that's actually at mandible level. So we can actually drop this about 2.5 to 3 inches. That ensures that we definitely won't get any of the jaw on the picture. I'll get a slough image. Just like that. Another thing that you don't want to forget is coning down, especially on a lateral projection. Not everyone's lungs are amazingly huge, so just remember to cone down, give you less exposure to the patient. And also, don't forget the marker again. And the most important thing, shielding. Don't forget shielding. And you're also at 72 inches away from the IR. And you do a left lateral because the heart is closer to the IR, and then you won't increase magnification of the heart. You want to make sure you select the right technique. On here, as you can see, there's a bunch of techniques already programmed into the system that you can pick. If you pick this one right here, the PHS on the wall bucky, you'll get a KVP of 117 with the outer 2 cells selected. Now, it's up to you, but most of the people will pick a manual technique, which you can change around to whatever you want depending on the body habitus. Say you like 121. All you have to do, and see, you can unselect any of these cells here. For a chest, you're mainly concerned with the outer 2 cells. Like that. And in here, if you want to, you can change it to the table, or you can change it to the wall, or you could do a screenshot. But we're going to stay right where we are right now. So that's about the technique you can use for a PHS.
2, 1.
Okay, now when doing a lateral chest x-ray, you want to make sure you pick on here. It's not the same as the PA, it's a lateral. The difference we choose this on the lateral is it's not the outer 2 cells selected in the AAC, it's the middle cell selected. So as you can see, it would use more mass. So on the manual technique, you can select the same KVP, or just about, we'll say 117, but instead of having these outer 2 cells selected, we're going to use just the middle one. That's it.
Hello, I'm standing here with Mr. Flatt today. He's clinical instructor at West Penn Hospital, and we just have a quick question. What are some reasons for commonly repeated exposures, you think?
There's a few things. If the
2, 1.
if the tube isn't lined up with the bucky, or the bucky isn't lined up with the tube and under the patient correctly, patient motion, patient moves too much, bad technique,
Artifacts?
artifacts, like chains. You get to remove a chain, earrings for cervical. That's a good example. Glasses for cervicals.
All right. 1.
Hi, I'm Megan, and I'm going to show you how to safely and wisely take images of the hand. We'll start off first by making sure that the tube is lined up properly to the table and also set at 40 inches. Another thing we need to make sure is that we use the right size IR, which for hands is usually a 10 by 12. When we bring the patient in, we need to make sure that the patient has no artifacts on the hand like rings or bracelets. We also need to check for cast or splints because if necessary, then we would need to increase our technique. So, Mrs. Jones, what brings you in today?
My hand's been bruised for the last couple of days. I didn't really fall or anything. It's just been giving me problems.
Okay. Any chance of pregnancy? Your date of birth?
6/12/91.
Go ahead and have a seat. And obviously, most important is to shield. So we're going to lay this right over her lap. images, you want everything to be in the same plane, your armpit, elbow, and hand. So go ahead and place your hand on the cassette. Since we raised the table, unfortunately, we're going to have to drop it down. Central array goes at the third MCP. Obviously, we want to make sure we collimate in to reduce scatter radiation, but still making sure to include all of the anatomy as well as make sure we put the right marker on, because we don't want to screw that up. So just that left marker on there. And we're ready to set the technique.
1.
For the second projection, we're going to do a PA oblique, and we'll center the hand in the middle of the cassette using a 10 by 12, and we're going to oblique the hand 45 degrees. We're going to place the central ray at the third MCP, just as we did in the first projection. And we're going to make sure we place our left marker on. And we need to make sure that we collimate down to reduce scatter, but also making sure we include on all anatomy, and obviously making sure that the shield is still in place. Our last and final projection is a lateral. We're going to have the patient fan her fingers out, placing the central ray at the second MCP. Making sure that her hand is in the center of the board here, which is a 10 by 12, and collimating down. Placing our left marker and making sure that the patient is shielded in the gonadal region. One of the most important things when imaging safely is setting the proper technique. There's 2 ways to do this on the control panel. 1, which is automatically set up, and 2, which is manually setting it. So since we did the hand, we're going to select upper extremity and hand. The kV range from 50 to 65 kV in between 1 and 6 or 8 mass, depending on the size of the patient's hand. Swelling, if the patient has a cast or any type of splint on the hand, then obviously we would see an increase.
This is Mike Collimation King of West Penn Hospital, and he's going to tell us the importance of collimation during an x-ray exam.
Well, Brandon, by far the first and foremost reason you want to collimate on your images is to reduce patient dosage. And not only patient dosage, but also physician dosage or x-ray tech dosage, or anybody that's involved in the procedure. Another reason you want to collimate is to improve image quality. By reducing and collimating, you can obtain a better image by reducing the divergent rays of the x-ray beam itself.
Bam.
Go ahead and have a seat. Always shut the door before you ask any information to your patient. So, Mr. Ron Jeremy, what pain are you having today? Where's that?
Pain in my right knee.
Pain in your right knee.
Yes,
How
sir.
long have you had this pain?
About 3 weeks.
Okay. Any upcoming surgeries? Any past surgeries?
No.
Okay. Did you have any accidents lately?
No.
Okay. Can I see your wristband, please? And you were born in 1970, July 1st? Okay. Shit, what was I supposed to do now? That's it, right? That's all we have to do. Yeah. Yeah, that's fine. Alright, let's go.